It's a pleasure to be with you today. I wish I could be with you in person at your meeting, but I've had the pleasure of being there many times in the past. I wish you well from Boston, and my goal today is to discuss you how I treat ITP. Often I give this talk to physicians, but this is a talk specially created, I think, for patients to give you a view of how I take care of my own ITP. So I work with many companies to develop new products for treating ITP, and I've done a lot of research in this area. And my goals today are to discuss with you some general aspects of ITP in terms of what platelets are. We'll talk about what ITP is. We'll discuss treatment options. We'll discuss subsequent therapies. We'll discuss refractory situations. We'll try to understand what it is that you as a patient value and prefer in terms of treatment approaches to your ITP. So let's start with something which we rarely talk about. When I see a new patient with ITP, most patients don't know what platelets are, so I begin by asking them, do you know what platelets are and what they do? And then I show them this picture. This is a 1910 microscope picture from James Homer Wright, who showed a megakaryocyte, which is a cell that makes platelets in your bone marrow, putting a part of its cell body, or it was called cytoplasm, into the circulation here, and it buds off these small things which are platelets. These then enter our circulation, and they have a special function. Clots are made by platelets. So this is a blood vessel. The platelets which we made in our bone marrow circulate here. They then encounter a hole in our blood vessels. So our blood vessels are shown here. They're coated with a shell called an endothelium. That's this word right here. And if you have a hole in that, you start to bleed. And platelets come along, these round balls here, and they plug up the leaks. And this gives you a plug at the site of injury. And this is how platelets work to prevent you from bleeding to death. In terms of ITP, ITP is a disease with your platelet count being low. So that platelet function of preventing bleeding tends to become much less. And so ITP is a problem with two issues. One is it's due to decreased platelet production, and it's also due to increased platelet destruction. So we have two forces on play here, destroying platelets and a problem making platelets. And I can summarize this by showing this picture. This is me. I used to be rather thin. I make platelets in my bone marrow. They enter my circulation. And after about 7 to 10 days, they're destroyed in my body and they disappear. Most of our platelets don't do anything. They just exist and are there for emergency use. If I develop ITP, antibodies appear in my circulation, and we all know what antibodies are now in our COVID era, but antibodies cause me to destroy platelets at a very fast rate, primarily in my spleen. And for many years, it was thought that our body compensated for this increased platelet destruction by raising platelet production, but that does not usually happen. What usually happens in ITP is we have an impaired rate of platelet production. The same antibodies that attack your platelets are also attacking your bone marrow and preventing your body from making new platelets. So in ITP, you're all destroying platelets at a very high rate, and you're failing to make them at an appropriate rate. And this gives you a chronically low platelet count, as shown by the few platelets in my belly here, in my homunculus. So this idea of platelet destruction and production gives you an idea of how you can treat ITP. In the white here are shown different ways to make the destructive process less. You can make the antibody disappear, for example, with rituximab. You can block the cells in the body called macrophages in the spleen that are chewing up the platelets, and that's with things like IVIG. Or you can simply take out the spleen, which is a therapy that's been present since 1918. So these are things that reduce the rate of platelet destruction, and if you reduce the platelet destruction, the platelet count will rise. In contradistinction are therapies such as the TPO receptor agonists, such as L-Thrombopeg, also called Revolade, and Remiflostim, also called Nplate. These are things that increase the rate of platelet production. So you can approach both sides of the ITP equation, decreasing destruction or increasing production, to allow us to treat patients with ITP. So coming back to you as a patient with ITP, if you walk into my office, how do I diagnose ITP? Well, if you come to my office, if your platelet count's below 100,000, we have a presumptive diagnosis as long as there's no other cause for thrombocytopenia. We sometimes worry if there's an underlying cause like lupus or chronic lymphocytic leukemia or other sort of benign conditions that can make this a secondary process. But most ITP is what's called primary. It has just happened for unclear reasons. And then we have become very modern. We describe the first 3 months of ITP as newly diagnosed. We discuss months 3 to 12 as persistent ITP. And if you had it for more than 12 months, which I think many of you or your relations have had, then this is called chronic ITP. In most patients, we don't need to do bone marrow biopsy. This is rarely needed. I do them in patients who are unresponsive to initial therapy, such as corticosteroids or IVIG. I do them if other blood counts are inappropriately low or high. And I do them in most patients in whom I'm considering taking out the spleen. But this is a very simple diagnosis to make, and sometimes we're wrong, most of the times we're right. So this is a key point. So when I see a new patient with ITP, such as if you came to my office, I would first try to recalibrate our view of what a low platelet count actually is. And many people come to me with platelet counts of 60,000, 70,000, and are scared out of their wits that they're going to bleed to death. And that's simply not true. You need platelets to plug up these holes in your blood vessels, but you don't need very many. And this is my little manometer here, or barometer. A normal platelet count's over 150,000. As the platelet count drops, when it gets below 100,000, we say it's ITP. When it gets to 50,000, most patients can not have any bleeding troubles unless you have other risk factors, such as if you're on a blood thinner, such as warfarin or an aspirin. And finally, most patients do totally fine at a platelet count of 30,000 if they don't have any risk factors for bleeding or need special medication. So in general, I don't usually treat patients in the absence of bleeding unless the platelet count's well below 30,000, usually below 20,000. So I try to recalibrate in a patient what an ideal platelet count is, just to make certain that we don't overtreat patients at 60 or 70,000 who don't need therapy at all. So first take-home message is when I see a patient, I'll recalibrate what our goals are and what a safe platelet count is. And I will tell most patients, as long as you're over 20,000 and aren't doing a dangerous sport like rugby, you're going to be fine. So this comes back to then when a patient's diagnosed with ITP, who warrants therapy? And again, this is not just based upon the platelet count. So it's not just the platelet count stupid, and I should write a book with that title. It's not just the platelet count. Other issues to be considered in terms of who gets treated are age, gender, particularly women with menstrual issues, diabetes, patients don't like steroids, the need for concurrent anticoagulation or procedures, the level of activity. A 18-year-old kid is different than an 89-year-old lady. I worry about their bleeding risk or bleeding history. I worry about occupation. I take care of a lot of professional athletes who want a high platelet count, and certainly pregnant patients are a unique group. So therapy needs to be personalized based upon a whole bunch of things. It's not just the platelet count. So if I can take you through a brief list of things I think about, if you're bleeding and your platelet count's below 30,000, most patients get treated. If all you got is a low platelet count, below 10,000 I usually treat, between 10 and 20,000 I often treat, but if you're over 20,000, I rarely treat patients with ITP. If you need a surgical procedure, a major procedure, obviously once your count's over 30 to 50,000, so many patients in this category require some therapy. For routine dental work, such as dental cleaning, I don't care what your platelet count is, nor do my dentist, and so we pretty much don't recommend or need therapy for that. If you need to be on a blood thinner, such as an aspirin or things like that, I want your platelet count over 20,000. If you need to be on 2 blood thinners, such as aspirin and warfarin, I want your platelet count over 50,000. So these are general guidelines as to who I treat, but in general, if you're not bleeding and you're above 20,000, I don't treat. So this comes to the topic I was asked to talk about, is what are the approaches to treatment? And this is an overall view of how I treat patients. Initial therapy, as many of you have had, is corticosteroids, sometimes IVIG. Most adults respond, and unfortunately, when you wean the steroids, the platelet count drops again. And my general algorithm, as I'll show you in a few minutes, is to use a thrombopotent receptor agonist as my main form of therapy. Most patients, 90-some% respond to these agents. If they don't, then I'll think about a different TPO-RA or rituximab. If these agents don't work, then we've got a whole list of other molecules here, fostamatinib, dapsone, danazol, or mycophenolate. And we have an abundant number of clinical trials for patients who are down in the tip of the iceberg here, in patients who don't respond to much of anything. In terms of splenectomy, some patients at the initial diagnosis just wanted to get it over with. In my experience, those are Air Force pilots who want to get back on their planes. I usually insist they get rituximab before going on to have their spleens taken out, but usually splenectomy, as I'll talk about, is reserved for later on. So this is my overall algorithm for how I treat ITP. So let's talk about individual patients, some of which may be familiar to you since you may be one. This is a 26-year-old lady. She's had heavy periods for 3 months. She's had easy bruising, but her platelet count's 23,000. Other blood counts are fine. She's sent to my office from her primary care physician office. She takes no medications. She's otherwise well. She has a normal physical exam. She doesn't have any oral blood blisters. And under the microscope, she's got a low platelet count, but her platelets are large. And I'll come back to that point in a second. And she has no other abnormalities. And this is where I talk to people. This is a patient who I'm not going to treat, I'm going to follow. But here's the important point, is to talk to the patient and discuss with them some important points. So my fellows call me the ITP whisperer, meaning that I talk to them about things maybe too much. I tell this patient, it's not leukemia. It's not a fatal disease. If you need to be treated, many therapies work. Normal life is possible, except possibly for playing rugby or bungee jumping. Most patients, if not all patients, have a remission at some stage. I'll discuss what a safe platelet count is. Our goal is to minimize therapy and keep the platelet count over 20,000, over 50,000 if there are other bleeding risk factors. I tell them there's no need to do bone marrow biopsy, and I'll say, let's go to the microscope. So I take my patients to the microscope and say, hey, your platelet count's low, here's a platelet, but they're large. And I don't know if any of you've seen your own blood in the microscope, but this is a blood smear. This up here is a normal size platelet. This is a large platelet, like many people in ITP. So as your platelet count drops, the platelets become much larger, and that's the body's attempt to try to compensate for the deficiency in platelet material. But in general, many patients at platelet counts of 20 or 30,000 have these gigantic platelets, many of which are not working, but all of which are highly functional. So coming back to the same patient, slightly different case, 26-year-old woman, heavy periods, easy bruising. Now her platelet count's 3,000. Other blood counts are fine. She's sent to my office. She's got oral blood blisters. She has petechiae. I do the ITP whisper discussion with her, but say, hey, your platelet count is too low to go home. And so in this patient, we'll treat this patient. And this brings us to what is the initial therapy. And this is my initial therapy primarily, and I hate to say this because I know you hate these medications, is corticosteroids. That's still a standard of care, I think. But as I'll talk about for a very short period of time, we give IVIG if you're bleeding, and we sometimes use anti-D, which is still a licensed product in North America. But here, as a new patient, you pretty much got to trust your physicians for these initial discussions. And as I'll talk about momentarily, later in the disease course, a patient's assessment of what you want or don't want becomes even more important. So the initial therapy, to summarize, when you come in, if this patient has a platelet count under 20,000, she does, I admit her to the hospital just to get the diagnosis established and to assess her care. I'll give her corticosteroids at a platelet count of 3,000. I will give her a short course, 6 to 8 weeks, and that's including tapering. So patients aren't on steroids for years. I will prefer prednisone over dexamethasone. I don't like dexamethasone. It oftentimes makes older patients go crazy. It oftentimes gives you a rather rapid rise in platelet count, but oftentimes you crash anywhere from 5 to 10 days later and are readmitted to the hospital. I give IVIG if there's major bleeding. But the key here is in a patient who's not bleeding, be patient. Don't expect within 24 hours things to all get better. It sometimes does, but it also sometimes doesn't. So a key here is to exercise patience in treating ITP if they're not bleeding. And this is where you got to be careful. My fellows and my residents in the hospital say, hey, things didn't work in the last 2 days. What do you do? Well, I wait a couple more days before adding on other therapies. So the initial therapy is corticosteroids, and I don't have time to go over what corticosteroids do in a positive way. You guys all know what it does in a negative way, but corticosteroids reduce destruction of platelets. They also increase platelet production, but a key thing that many of you don't know is it makes your blood vessels tighter. It prevents leakage of blood vessels. And this is a nice cartoon picture or a picture of blood vessels. Normal blood vessels are lined, as I mentioned, by this thing called the endothelium, which is nice and thick. If you're thrombocytopenic, this endothelium becomes very thin and becomes porous. Holes appear here, and red blood cells seep out here into your skin and give you petechiae. And what's neat about this is the following. If you measure a normal endothelium, it's thick with no holes in it. If I make you thrombocytopenic, it becomes thinner and has lots of holes. If I give prednisone, it becomes thicker within hours and the holes disappear. And this is why many patients experience a reduction in bleeding without a rise in platelet count when corticosteroids are started. So coming back to my lady, she's had heavy periods. Her platelet count's 3,000. I say to her, hey, you got to be admitted. We admit her for a diagnosis of ITP. We give her prednisone 60 milligrams a day. Her petechiae resolve within 1 day, as I mentioned, because they tighten up the blood vessels. Her platelets are 26,000 by day 2. We send her home on 60 milligrams of prednisone. This is a course I think many of you might have experienced. And a week later, her platelet count is 175,000, which is normal. The story continues. Since I promised her to keep her on prednisone for a short time, over weeks 2 to 6, we weaned prednisone to 20 milligrams a day, and her platelet count still is over 50,000, which is fine. But at week 7, platelets dropped to 14,000. She's on 15 milligrams of prednisone, and here's where we have to think. And many of you have been in this situation. 80% of adults respond to ITP therapy with steroids, but most patients, when you wean the prednisone, don't maintain that response. So the real question is, what do you do next? And so here's the second aspect of therapy. What is the subsequent treatment for ITP? Is it asplenia, a new disease created by taking your spleen out? Is it a thrombopotent receptor agonist? Is it rituximab? Is it the drug fostamatinib? Or are there other immunosuppressive agents we're going to use in this particular setting? So the first message I have to you, I'm going to give with one hand and take it away, is asplenia, taking your spleen out, works. 85% of patients respond to it if it's done in the first 3 months, and that response lasts for about 10 years. It's important to note that a third of these patients would have responded had you just waited for 6 to 12 months, but this is the data that exists. The problem with asplenia is it's got side effects, and you all know the side effects. The first is there's an increased risk of what's called venous thromboembolism, also called blood clotting. These are ITP patients whose spleens have been taken out. These are ITP patients who haven't had splenectomy, and there's a 3 to 5-fold higher rate of blood clots. The second issue, as you all know, is that splenectomy can increase your rate of infection. This is the asplenic patients with ITP. These are the ITP patients without splenectomy, and the infection rate's about 2.5 or 3 times greater. But these are not real major reasons to not splenectomize patients. The real reason is this: most adult patients attain a remission without splenectomy. And there's a lot of data, and one of your advisors, Dr. Newland, has been a key in terms of creating this data, but I'll cite some different data, which is this. This is a study from Austria. These are patients, years from diagnosis. And if you ask who got a platelet count over 30,000, by year 1, almost 70% of patients have a platelet count in a safe range with no splenectomy. By year 5, this rises to almost 90%. So most ITP patients, if you can wait long enough with medical therapy, don't require splenectomy. And that's a key message I give to all my patients, and I'm giving you today in terms of how your therapy is conducted. So other therapies for ITP you're familiar with. Rituximab has been around for a long time. It was thought by our colleagues in Britain, and many are with you on this meeting today, that rituximab might cure ITP. It probably doesn't. Rituximab gives you about a 60% response rate. By year 1, that drops to 39%. By year 5, that's 21%. So it works, but it doesn't cure patients of ITP. So we've talked about splenectomy briefly, rituximab even more briefly. And the major therapy, I think, for ITP patients is using thrombopotent receptor agonists. These have response rates well over 80 to 90%. The responses are maintained as you give the medication. They have very minimal side effects. The real problem is they're not cheap. These are very expensive medications, unfortunately. And the 3 that are available for ITP are ramipostym, eltrombopag, avatrombopag. Their brand names you may know as Nplate, Revolade, and Doplet. These 3 agents all have very high response rates, are widely used. I don't have time to go into the differences. I'll simply go over them briefly. Ramipostym, eltrombopag, avatrombopag. This is a subcutaneous route. Eltrombopag and avatrombopag oral. Eltrombopag is probably the weakest in terms of stimulating a rise in platelet count. Ramipostym much more potent, and avatrombopag in the middle. Eltrombopag, as many of you know, has to be taken on a special diet. The dose is reduced if you're of East Asian ancestry or have concurrent liver dysfunction. The other 2 drugs, avatrombopag and ramipostym, don't have these dietary or liver restrictions. They're all safe if you have renal failure. and none of them should be used routinely in patients who are pregnant. If you've got a desperate pregnant patient, I would probably prefer this over the others. So coming back to my patient, we've given her prednisone for 6 weeks. Her platelet counts now dropped to 14,000. She's on 15 milligrams of prednisone. We do not want to keep her on prednisone much longer. So what do you do at this point? Well, at this point, you discuss with the patient her values and preferences. And what does this mean? This is how much fear and anxiety is there over a low platelet count? How much does a patient accept a low platelet count? What's your tolerance for minor bleeding? What's your activity level? What's your acceptance of taking a therapy every day or every week? What's your desire to avoid the bad drug, corticosteroids? What's your desire to avoid splenectomy? And what's your desire to say, let's get this all over with, take my spleen out, make me all better? And here's where patient's view of the world is more important than the physician's assessment. So at this point, down the road in ITP, I talk to my patient and say, hey, here's the situation, and let's go over the options. So coming back to this patient, I will say, hey, you've not done well, you're relapsing. I discuss with her values and preferences. I'll discuss that I would prefer to defer splenectomy for at least 12 months. And I'll say my preference is a thrombopotent receptor agonist has a higher response rate over rituximab if these drugs are covered by your insurance policy, which fortunately in the United States, they usually are. So she started on an oral agent, L-Thrombopeg, which many of you may know at the highest dose, 75 milligrams a day. Her platelet count doesn't rise a lot, but it goes from 3,000 to 30,000. She's feeling fine. And then after 12 months on the maximum dose, her platelet count's still 26,000. And the question comes, what do you do next? And here's where I go back to my ITP whisperer mode again. And what I do in this situation is I sit down with the patient and say, hey, was the ITP initially responsive or non-responsive to steroids? Her disease was highly responsive to steroids, so I think she has ITP. But at this situation, some patients who haven't responded well to steroids or TPO-RA, you've got to reassess the diagnosis. You've got to reassess the goals of therapy. You've got to consider the benefit of treatment versus the adverse events of the therapy and the costs. And here's where a bone marrow examination may be helpful in a patient who's now non-responsive to 2 therapies, steroids and a TPO-RA. So coming back to her, the question is, what's the next course of action? She has responded to steroids. I'm certain she has ITP. We could continue the TPO receptor agonist. She's doing fine. She can be on it for years and have a normal life at 26,000. We could change her to another TPO-RA, and oftentimes when you do that, the response rates rise to 80%. We could give her rituximab or mycophenolate. We could give her fostamatinib. We could take her spleen out. We could put her on a clinical trial. And here's where she and I discussed what we want to do. And she said, hey, I'm doing fine. I'm not going to be pregnant for many years. I'm doing fine on the pill once a day. Let's just wait and watch. So in her case, we kept her on a TPO-RA, but we could just as easily switch to another TPO-RA or put her on rituximab. So coming back to the overall algorithm, corticosteroids and IVIG initially, and those who don't have a cure of the disease by steroids, I usually give a TPO-RA. And at this point, some 90% of patients have responded. And those who haven't responded like this lady optimally well, I'll probably switch to a TPO-RA of a different type or give rituximab. This probably takes care of the remaining 3 or 4%. We're down to the tip of the iceberg, 3 or 4%, who then I'll probably either add fostamatinib, dapsone, danazol, mycophenolate to these somewhat refractory patients, or consider a clinical trial. At some stage, the question is, do I ever do splenectomy? And the answer is, I rarely use it. I've done it twice in the last 20 years on a database of probably 1,800 ITP patients. I only consider it if a bone marrow biopsy and genetic studies have been done to exclude other bone marrow diseases. If I'm considering that I want to insist they've failed a prior trial of rituximab, I'll complete vaccinations as if I've got time to do that. And I want them to understand the full consequences of living with a new disease, which is having no spleen. So to summarize, and this is my last slide, many patients with ITP don't require therapy. The initial therapy is corticosteroids, IVIG if you're bleeding. Splenectomy works, but it has some side effects. I will delay it at least for a couple of years because most ITP patients don't remain chronic. Remissions do occur. And finally, I leave you with the word, give medical therapy a chance before considering splenectomy. Having said this, what's important to note is we are working on a cure for ITP. On that note, I'll leave you and thank you for your kind invitation to talk to you today about my preferences for how ITP should be treated.